In fact, growing data coming out of Ukraine, they've got a bunch of the tourniquets over there, and we've been able to track about 3 dozen lives saved that had a Roll 1 application to a Roll 2. And we've been working actually with a vascular surgeon over there who was the senior medical officer for the 59th Motorized Brigade, and they used the device at the Roll 2 as well, just simply to stop the bleeding, turn the faucet off, because some of these wounds from artillery hits are just devastating. They're just mangled. And so it's hard to even identify where the bleeding is coming from, how many vascular structures are injured, and it takes a little while just to identify the anatomy to know what to fix. One of the reasons that the AAJT became the junctional tourniquet of choice with special operations was when we apply it, we then move patients, obviously. And in that Roll 1 environment, moving means bending, hoisting, dragging at times. And the ability to move that patient without losing hemorrhage control was obvious necessity. Because if we lose hemorrhage control before we get to the Roll 2, then my surgeons start behind the 8 ball. If somebody is in shock on their arrival, and we have ways of trying to help with that. Now we're deploying blood more forward than we have in the past. So sometimes the evacuation resource, even if the conventional unit on the ground doesn't have blood, can actually provide blood en route. But stopping the flow is important, and not losing that hemorrhage control during movement is also very important.